Our dyad is comprised of Hannah Senko and Seth Senko, and our DMP chair is Beth Crochet. We chose to do our project on nebulized dexmedetomidine for direct laryngoscopy. Stressors that are prolonged, intense, or repetitive can elicit harmful effects within the body. A prime example is direct laryngoscopy, or DL. DL leads to the release of catecholamines and increases cortisol, causing hypertension, tachycardia, sodium retention, and hyperglycemia. This can increase morbidity and mortality surrounding general anesthesia. The goal of this project was to evaluate data on the use of nebulized dexmedetomidine to blunt hemodynamic response to DL in adults. The gate control theory of pain provided a framework to evaluate dexmedetomidine's influence on the stress response. The results intend to increase knowledge and use of nebulized dexmedetomidine before direct laryngoscopy. Direct laryngoscopy is performed to facilitate tracheal intubation. Direct laryngoscopy is a noxious stimuli that induces a stress response evidenced by an elevated heart rate, systolic blood pressure, and diastolic blood pressure. The body activates the sympathetic nervous system, signaling the adrenal glands to release catecholamines and cortisol. Catecholamines can lead to myocardial ischemia and an oxygen supply and demand mismatch. Cortisol surges can increase sodium retention, elevate blood glucose, and alter the immune response. These effects may increase morbidity and mortality for surgical patients. There are several prevention modalities. Fentanyl, esmolol, and occasionally Precedex or dexmedetomidine have been given to blunt this response. Dexmedetomidine possesses sedative, anxiolytic, and analgesic-sparing effects and can be administered via intravenous, intranasal, or a nebulization route.
The intravenous route of dexmedetomidine to blunt response to DL and endotracheal intubation has been extensively researched and compared to other medications. It has been found to be effective in mitigating heart rate and blood pressure elevation, but also tends to result in profound hypotension, bradycardia, and respiratory distress. Intranasal routes of dexmedetomidine administration have also been researched, while beneficial, have been associated with nasal irritation. Nebulized dexmedetomidine is an off-label route that has a high bioavailability and absorption, without irritation and precipitous decreases in heart rate and blood pressure. The aim of this research is to determine the efficacy of nebulized dexmedetomidine in blunting the hemodynamic response to DL. The gate control theory of pain, developed by Ronald Melzack and Patrick D. Wall in 1965, proposed that pain signals must pass through a neurological gate in the spinal cord. The gate chooses which signals will be carried on to the brain and which will not be allowed to pass. The intensity of the pain determines the degree of openness of the gate. The gate can be closed by influencing large, rapid conducting fibers and decreasing small fiber activity. The gate control theory of pain serves as a guide to aid in understanding how dexmedetomidine can blunt the hemodynamic response to DL. DL and tracheal intubation cause a pain response which results in SNS discharge of neurotransmitters and catecholamines into the systemic circulation, resulting in hypertension and tachycardia. Neurotransmitters act as messengers, binding to receptors to either increase or decrease signal transmission between nerve fibers. For pain to be perceived and processed, there must be a release of these transmitters. Dexmedetomidine alters the pain response by inhibiting the release of neurotransmitters, thus reducing the activity of the sympathetic nervous system and subsequent pain response. It works to close the neurological gate by inhibiting transmission of large pain fibers, known as A delta fibers, and large, slower C fibers, preventing transmission of pain signals to the brain. Dexmedetomidine also possesses a central analgesic effect by inhibiting the release of nociceptive peptides, further decreasing spinal cord pain signaling.
Dexmedetomidine agonizes alpha-2 receptors to cause anxiolysis, decrease pain, and sedation. Through its action, it can be used to blunt hemodynamic response to DL and tracheal intubation. There is extensive literature on the use of IV dexmedetomidine before surgery. While very effective and beneficial in blunting the hemodynamic response to DL, this route of administration has been shown to cause bradycardia and hypotension. Nebulized dexmedetomidine, with a potentially more favorable safety profile than its IV counterpart, is a novel route of administration that has been investigated in 4 randomized controlled trials. This systematic review seeks to understand the benefits of nebulized dexmedetomidine given preoperatively in blunting the hemodynamic response to direct laryngoscopy. Types of participants included were adult patients above 18 years of age. A specific inclusion criteria for this review were patients of American Society of Anesthesiologists or ASA status 1 or 2. Only patients undergoing general endotracheal anesthesia were recruited. 3 studies contained patients undergoing elective short-duration operations, while the 4th study evaluated patients undergoing laparoscopic procedures. Any patients deemed a potentially difficult intubation were excluded. Patients with multiple comorbidities and an elevated BMI above 30 were also excluded. Other exclusion criteria of this review were studies that evaluated pediatric patients and those in which animals were utilized. Types of interventions. The use of nebulized dexmedetomidine to blunt the hemodynamic response to DL was the phenomenon of interest. Only elective, non-emergent intubations were included. Studies that evaluated IV dexmedetomidine and intranasal dexmedetomidine were excluded from this review. Comparisons. 3 studies included in the review compared nebulized dexmedetomidine to nebulized saline. 1 study compared nebulized dexmedetomidine to nebulized saline with a co-administration of intravenous dexmedetomidine and nebulized saline with co-administration of intravenous fentanyl. No studies were excluded for their comparison group designs. Types of outcome measures. The primary outcomes of interest for this review were hemodynamic parameters after DL. This was evidenced by post-DL interval heart rate, systolic blood pressure, diastolic blood pressure, and MAP measurements. Several secondary outcomes were also described, such as dosage of propofol required for induction and opioid needs. Studies addressing postoperative sore throat incidence and effects on pulmonary shunting were excluded. Types of studies. All methodologies were considered during the initiation of the literature search. The only resulting methodology that met all criteria were randomized controlled trials. According to the National Health and Medical Research Council evidence hierarchy, RCTs are considered level 2 evidence and deemed the gold standard when it comes to evaluation of an intervention or treatment. RCTs are surpassed only by systematic reviews of RCTs, which may include meta-analyses.
An extensive systematic literature search was performed with librarian oversight by 2 doctoral students. A research question was formulated and utilized to obtain effective search terms. This can be seen on Appendix A. 6 databases were then searched: Medline, Cumulated Index of Nursing and Allied Health Literature, also known as CINAHL, ProQuest, Cochrane Central Register of Controlled Trials, PubMed, and Ovid. Population search terms included patients undergoing general anesthesia, tracheal intubation, endotracheal intubation, laryngoscopy, and induction of general anesthesia. Search terms used to define the intervention included preoperative nebulized dexmedetomidine, nebuli dexmedetomidine, aerosoli dexmedetomidine, vapor dexmedetomidine, alpha-2 agonist, and alpha-2 agonist, abbreviated. Search terms used for the outcome of interest were hemodynamic response to direct laryngoscopy, SNS response, hypertension, heart rate, and blood pressure. Boolean operator and was used to combine terms for different categories, and Boolean operator or was used for search terms within each category. Apply equivalent subjects was used as a search expander. The search was limited to articles published between 2016 and 2022. Articles were also limited by peer-reviewed. The search produced 121 articles. This can be seen in Appendix B. Results were combined, and both members of the dyad deleted 22 duplicates due to a lack of applicability to the topic of interest. 33 articles were also removed. The final 43 articles were screened for inclusion and exclusion. This PICO search strategy chart was used to guide our literature search.
During the literature selection process, a Prisma flow diagram was used to guide the screening. 43 articles were screened by reading their abstract and titles. During this process, 38 records were excluded by the dyad members. These articles were excluded due to a lack of applicability to the research question. The full text of the 5 remaining articles were analyzed by the dyad to assess for applicability to the topic of interest. The dyad also performed a critical appraisal of the 5 articles, utilizing the 2017 Joanna Briggs Institute checklist. 1 article was removed after dyad agreement because it did not align with the outcome of interest. The remaining 4 articles were included in the systematic review. This Prisma flow chart shows the results of our literature searches, which were whittled down to 4 randomized controlled trials that met all criteria. Results for our primary outcomes of interest included: Kumar et al. Found a decreased systolic blood pressure post-DL in the nebulized dexmedetomidine group compared to their control. Mishra et al. Found a decreased heart rate post-direct laryngoscopy with the use of nebulized dexmedetomidine pretreatment compared to control. Shankar et al. Found a lower trend in heart rate and systolic blood pressure post-direct laryngoscopy with nebulized dexmedetomidine compared to intravenous fentanyl with nebulized saline, but lacked a true control. Srivastava et al. Found a decreased heart rate and systolic blood pressure in the nebulized dexmedetomidine group compared to their control. In terms of secondary outcomes, Kumar et al., Mishra et al., and Srivastava et al. All found decreased propofol requirements in the nebulized dexmedetomidine group compared to their control. Shankar et al. Also found decreased propofol requirements in the nebulized dexmedetomidine group, but lacked a true control. Lower fentanyl requirements were seen in the nebulized dexmedetomidine groups compared to control in both Mishra et al. And Srivastava et al. Srivastava et al. Found no difference in sedation scores between nebulized dexmedetomidine and control groups. There was a decrease in entropy in the nebulized dexmedetomidine group reported by Kumar et al. When compared to control.
3 of the RCTs compared the effect of nebulized dexmedetomidine to that of nebulized saline before induction of general anesthesia. The 4th randomized controlled trial compared nebulized dexmedetomidine to the combination of nebulized saline and IV dexmedetomidine and nebulized saline with IV fentanyl. The 4 studies all had similar demographics, large sample size, and similar anesthetic techniques. All studies used the same nebulization dose of 1 microgram per kilogram of dexmedetomidine nebulization, with a varying amount of saline as a carrier solution. When compared to control groups, Kumar et al. Found no statistically significant change in heart rate with use of nebulized dexmedetomidine, while Mishra et al. And Srivastava et al. Found significant decreases in heart rate post-induction and DL. Mishra et al. Found no difference in systolic blood pressure post-induction in the dexmedetomidine group, while Kumar et al. And Srivastava et al. Found a statistically significant decrease in systolic blood pressure at 5 minutes post-induction and DL. Shankar et al. Found decreased heart rate and systolic blood pressure post-laryngoscopy with both IV and nebulized dexmedetomidine groups, but there was a lack of a true control. While there is no true control, results are beneficial as nebulized dexmedetomidine is compared to one of the most common drugs used to blunt hemodynamic response to DL. 3 studies found that the nebulized dexmedetomidine group required less propofol for induction of anesthesia than the control groups. Shankar et al. Found a reduction in propofol dose in both intravenous and nebulized dexmedetomidine groups, but provided no true control. Mishra et al. And Srivastava found lower fentanyl requirements in the nebulized dexmedetomidine groups compared to control groups. Srivastava et al. Found no differences in sedation scores utilizing an observational sedation assessment. Between the nebulized dexmedetomidine groups and the control groups, Kumar et al. Found a decrease in entropy in the dexmedetomidine group and described a patient that was relaxed, but able to swiftly follow commands before induction. This research can be assigned a grade B and a moderate level of certainty according to the U.S. Preventative Services Task Force. This level of certainty means that the evidence is adequate to determine an effect of the intervention to a health outcome. However, full confidence is hindered by the inconsistency of the findings regarding heart rate and systolic blood pressure results. There are a few limitations concerning the studies involved in this review. 3 of the studies were conducted in India and 1 in South Korea, representing only 2 demographic regions. The population sampled, while generous in size, did not include those with various comorbidities, nor an ASA class greater than 2. This limits the generalization of results to those with health conditions or of a higher ASA class. These studies also included only elective, non-emergent, non-cardiac, and non-neurosurgical cases. The restricted patient characteristics within the studies limits the applicability of findings to the general surgical population. The studies included in the systematic review were found to have several strengths. All studies included were randomized control trials, representing an increased level of evidence presented in this review. The studies all addressed similar outcome measurements and utilized non-invasive basic vital sign assessment tools. The studies each evaluated large sample sizes averaging 100 participants. The study participants were uniform in gender distribution and age across the studies. Within each study, participants were also given similar anesthetics, with the same weight-based dosing and drugs across intervention and control groups, decreasing risk of extraneous variables altering results.
A sympathetic surge followed by an increased heart rate and blood pressure are anticipated responses to DL and endotracheal intubation. There are various medications and methods that attempt to mitigate this pain response in the operating room. While 2 studies found differing heart rate or systolic blood pressure results compared to the others, the overall evidence showed support of dexmedetomidine as an acceptable agent to blunt this hemodynamic response to laryngoscopy. Shankar et al. Did not provide a true control group, limiting its application. There is still a need for increased research that explores the efficacy of nebulized dexmedetomidine in a more diverse patient population with increasing comorbidities.
The current body of evidence is too limited to support a push to make nebulized dexmedetomidine common practice. When comparing nebulized saline and nebulized dexmedetomidine, 2 of the 4 studies found a decrease in heart rate post-DL, while 2 of the 4 studies found a decrease in systolic blood pressure post-DL. Shankar et al. Showed a decrease in both heart rate and systolic blood pressure in the nebulized dexmedetomidine group, but did not compare results to a true control. Anesthesia providers should consider using nebulized dexmedetomidine and anticipate more studies that will evaluate its safety profile and its efficacy. There is a current and much needed push towards opioid-free or opioid-decreased anesthesia. Mitigation of opioids within the perioperative period can decrease opioid-related adverse effects. Currently, the use of nebulized dexmedetomidine is an off-label and unapproved route of administration. The evidence presented supports the consideration for inclusion of nebulized dexmedetomidine into practice. Additional studies should be performed to further confirm the safety and efficacy of nebulized dexmedetomidine, as the studies mentioned are concentrated in only 2 geographical areas. It would be beneficial to see studies from more countries, mirroring the same results. There is also a need for studies to be performed that include patients with comorbidities and those of higher ASA classes. Studies should be conducted to determine the optimal time for administration prior to anesthetic induction. There is a need for studies evaluating intubations in non-surgical environments, such as critical care or emergency settings. Additionally, more research is warranted to increase confidence in the recommendation of nebulized dexmedetomidine before DL. As more studies are conducted, it is likely that nebulized dexmedetomidine will become a key method to reduce hemodynamic response to DL and improve patient outcomes.